Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. One of the programs that's been targeted for federal cuts is Medicaid, the healthcare safety net, which covers many living below the poverty line and much of the long-term care for disabled and elderly people. Today, Johns Hopkins experts Gerard Anderson and Jennifer Wolff talked to Stephanie Desmon about the potential risks to beneficiaries, hospitals, nursing homes, and more. Let's listen.
Gerard Anderson and Jennifer Wolff, thanks so much for joining me.
It's great to be here today.
It's always great to be invited back.
Gerard, I want to start today. First of all, the topic today is going to be Medicaid. So just remind people what Medicaid is, because sometimes people get confused.
Sure. Well, it's a state-run program, and it's really two very different programs. One program is for children and for adults, and the other one is people who are eligible for both Medicare and Medicaid, which are called the dual eligibles, and then people that are involved in long-term care. So what I'm going to do today is talk about the issues related to children and adults, and Dr. Wolff's going to talk about the dual eligibles and those in nursing homes. It's basically Medicaid is a state-federal partnership. So the states have a lot of ability to set the coverage policy, what services they're going to offer, who's eligible for services, and the payment policies. And what the federal government typically does is provide some very broad general guidance on what services need to be covered, how to cover those services, and how much to pay for those services. The reason why the federal government's so involved is that it does pay a very large share of the cost of the Medicaid program. Precisely how much the federal government pays is a factor of the state's per capita income, what specific person is covered, and a whole variety of other factors. And what the Congress is discussing right now is how to change this policy, and it really is almost all about the whole issue of who's eligible and how much and what the coverage is going to be. There's very little about the payment side, which is typically what we talk about when we're talking about Medicaid.
So just as a reminder, Medicaid is the healthcare safety net for people who don't have very much money. These are for the poorest, people who don't have insurance otherwise.
Correct.
So what we're talking about here is that we're concerned that there's going to be deep cuts to Medicaid because the administration's cutting lots of things. Is that what we're seeing?
Right. And Medicaid has always been a historical target for the Republicans, and they're looking to take anywhere from $600, $800 billion out of the Medicaid program over the next 10 years, which is a huge percentage of the Medicaid budget and a huge percentage of what the federal government pays. And so what it's going to mean to a large extent, if the states want to continue the coverage in the same way that it's being covered now, they're going to put up a lot more money in the state budgets, which most states don't have. So that's going to be a serious problem for the states, for the people that are covered by Medicaid, and for the hospitals and physicians that provide services to those people that are covered by Medicaid.
So, Jennifer, Medicaid expanded wildly over the past decade or so. Talk to me about who's covered under Medicaid and what happens if the spigot turns off.
Sure. So Medicaid has expanded, notably, as you suggested, related to the Affordable Care Act. And so many individuals who otherwise were unable to access health insurance through the labor market and who are eligible for subsidies through Medicaid. So that has expanded the role of Medicaid in through insurance coverage and the budgetary impacts that the federal government is paying through the match that Dr. Anderson just mentioned.
Jerry, are these cuts feasible? I mean, can we really cut that kind of money out and still have a program?
Yes, you could, but what you got to recognize is who is really being covered by the Medicaid program. And it's 1 out of 5 people in the United States have coverage through the Medicaid program. So you're going to ask them to take either cut a lot of people or for them to get a lot fewer services. It actually represents 1 out of every $5 that's spent on healthcare. So if I'm a hospital, if I'm a physician, and you start cutting these monies, it means that the hospital has less money. The physicians have less money. And it really varies from state to state. So on average, I said 1 out of 5 people have Medicaid coverage. But in Utah, it's only 1 in 10. And in New Mexico, it's 1 in 3. So this program change will have a huge impact in some states and have less, but still a very significant impact in other states. Also, it covers 4 in 10 children, over 8 in 10 children in poverty, 1 in 6 adults, and half of the adults in poverty. So it really affects a large portion of the American public. And when you cut $600 to $800 billion from it, something is going to have to change. Somebody is going to have to suffer.
So how is this being rationalized?
Well, essentially, to cut $600 billion, they've got 4 plans that we think of. The first one is called work requirements, and that's for adults or people without disabilities or people without young children, and they have to work. And this makes complete sense if you think about it without thinking very hard. People should, in fact, be able to, if they could work, they should be able to get off of Medicaid. But the fact is that many of these people are in very low-wage jobs, and so even if they are working, they're still going to be on Medicaid, people at Walmart and places like that. But also, many of these people are in very rural areas in the United States, and there aren't any jobs. And so you're telling somebody to go out and get a job when there are no jobs in their community. So then what you're saying to them is move to another community. Well, the community that they're leaving from is probably low income. They probably don't have a house. And now you're asking them to move to a more affluent area where they can't afford the rent because they don't have and they might not have a great skill. So it sounds really good, but you can't do it. The second area is continual monitoring of eligibility, which means, are you having a certain level of income? Do you still live there? A whole set of things like that, which, again, makes complete sense. But these people might not have telephones. They might not have iPhones. They might have to go somewhere and travel 2 hours to actually say that they are eligible for coverage. So, again, it sounds good, but it's not feasible when you're in a rural area or if you don't have a car or something like that. And many of these people with Medicaid don't have cars. The third one, and this is actually one that I sort of agree with, is you limit the ability of states to tax hospitals for their share of Medicaid revenues. And so what hospitals have been doing is saying, we will pay a tax, and therefore you, the state, will get money, and we, the hospitals, will get more money from Medicaid because we're giving you money. So it's a way to take money away from, it was for the states not to pay anything more, but the federal government to pay more. And we've been working with a number of states. One that we're really upset about is North Carolina, which has done this. But it does take away a lot of money from hospitals, and hospitals will fight this tooth and nail so that it doesn't, and in fact, happen. You could reduce the amount that the federal government pays for working class adults that became eligible because of the Affordable Care Act, Obamacare, and they got an extra payment as an inducement to enroll people in Medicaid. That's been essentially could be taken away. Essentially, you promised the states that you would give them this money if they expanded, and now you're taking it back. So again, you could do it, but it's essentially reneging on your agreement with the states. And if I was the state, I'd be really unhappy.
So, Jennifer, the disabled and long-term care beneficiaries are two sets of people who are impacted by this that you might not think of. So could you describe those communities and then tell us what it looks like for them?
Sure. Yeah. So Medicaid was developed as a means-tested, open-ended entitlement program for people who were not expected to be in the labor market. And this includes people who are old, who were in 1965 when Medicaid was passed, older, and who are living with disabilities. And Medicaid has just an incredibly important role in providing care and support for these populations. Medicaid is the largest funder of mental health and substance abuse care disorders and the largest single payer of long-term services and supports. It accounts for 60% of all paid care related to support for people with disabilities. So the role of Medicaid in long-term services and supports far exceeds that in healthcare. So where Medicaid funds about 20% of hospital care and about 10% of care to clinicians, but about $3 and $4 in nursing facilities, as an example. And the people who are enrolled in Medicaid with disabilities have incredibly complex needs. They bridge both functional impairments as well as medical complexity involving co-occurring conditions like diabetes, obesity, mental illness, and age-related impairments like Alzheimer's disease and related dementias. The individuals who are both duly enrolled in Medicaid as well as the Medicare program are twice as likely as those who are only enrolled in the Medicare program to have 5 or more chronic conditions, to have mental health disorders and disabilities in daily activities, and they're about 10 times as likely to have Alzheimer's disease and related dementias. For this reason, the subset of people who are enrolled in both Medicare and Medicaid due to age and disability represent about 1 in 4 of Medicaid enrollees, but account for more than half of all Medicaid spending. And just to reinforce the comments of Dr. Anderson, given the low income and extensive care needs of this population, they really are not good candidates for being able to absorb funding cuts or greater out-of-pocket spending. Basically, the entire population in this group who are duly enrolled for both Medicare and Medicaid are living with annual incomes of below $20,000, and nearly half are, about 4 in 10, have annual incomes of less than $10,000. So they are an incredibly vulnerable population, both in terms of health as well as financial assets and resources.
Jerry?
So I think Dr. Wolff's done a great job. The only thing I would add was the fact that most people, say you're 50 years old and you're thinking about retirement and you're thinking about your long-term care needs, think Medicare is going to handle that. And Medicare doesn't handle that. It is the Medicaid program. And so, if you're thinking about what's going on in your future, you've got to recognize that Medicaid is very important to you. Medicare does provide a very short period of time for skilled nursing facilities, but if you're going to be in there for a while, Medicare is not going to cover you. It's going to be Medicaid, unless if you're a low-income individual.
Jennifer?
Sure. I guess as we're talking about benefits and what is covered through Medicaid and some of the implications of potential budget cuts, it's really important to understand what Medicaid covers and the difference between statutory benefits, which are mandated by federal guidelines, and optional benefits, which are sort of at the state's discretion. And so it is true, Medicaid has mandated benefits in long-term services and supports that include nursing home care or institutional care. And this has led to having a traditional orientation and a structural bias towards institutional care that most people don't desire. and is more expensive. So the average annual costs for nursing home care in a semi-private room exceed $100,000. So states have been very innovative in pursuing optional benefits like personal care, assistive devices, environmental modifications, and adult daycare. These are sort of home and community-based supports. The spending that Medicaid devotes for long-term services and supports are now more than half of it is for home and community-based supports. But as Dr. Anderson said, there's tremendous variability across states. One of the issues is that the innovation in Medicaid has been really exciting and important for people living with disabilities. But because those benefits are optional, the cuts to Medicaid, if they roll out to these populations, will disproportionately inhibit care for in the home and community. And so this is basically everything that Dr. Anderson said about the implications of cuts have huge ramifications in the long-term services and support space, both in terms of decimating the nursing home industry, as well as reducing accessibility of home and community-based supports for people who are low income and have incredible complexity in their health.
I want to give Jerry the last word here. Look into your crystal ball. Tell us what we should be looking for in the next weeks and months and what these outcomes are likely to be.
So there are a number of Republicans in districts that are very dependent on Medicaid. So the question is, how will they vote? Will they vote to cut Medicaid and take money away from their district, or will they not? For example, I took a look at 3 Republican districts, one in eastern Louisiana, which is actually where the Speaker of the House is from. 1/3 of his population is enrolled in Medicaid. In rural Kentucky, where a number of Republicans are in, 40% of the population is enrolled in Medicaid. And in rural California, almost 70% of the population is enrolled in Medicaid. So if I'm a representative and I say, I'm going to lose 40% of my coverage or some percentage of that, or 40% of my revenues for hospitals and for people, I'm going to have to think very hard about that, but never figure out what the politicians are going to do. If I was a politician and I was going to take a big cut to my people that are in my district and my hospitals and my physicians, I'd have to think really, really hard.
Jerry Anderson, Jennifer Wolff, thank you both so much for joining me.
It's been a pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.